All right, and this is part 2 of the first lecture for CNS 5450. And we have now brought ourselves in the history of counseling all the way up to the 2000s. And something that has been really important in the 2000s is that the broad profession of counseling has been getting more clear on exactly what it is. And that might sound kind of strange, but over the decades that we've previously discussed, there were many different groups that said that they do counseling, but who really is a counselor and who gets to have that professional credential and title? And so groups that are prominent in the field of counseling have had to come together, and they had to agree on one definition of what counseling is. And this is something that I would like for you to commit to memory. Professional counseling is a professional relationship that empowers diverse individuals, families, and groups to accomplish mental health, wellness, education, and career goals. If anyone asks you, oh, you're a counselor, what do you do? Is that like being a social worker? Is that like being a psychologist? Nope, it's like being a counselor. And here's what it is. It's a professional relationship that empowers diverse individuals, families, and groups to accomplish mental health, wellness, education, and career goals. So make sure that you remember that, please. As counseling has evolved, all of the different models and theories of counseling that have been part of the profession growing and learning how to understand and conceptualize people and their concerns and problems. There's been more emphasis on what are the common factors that are effective across all counseling theories. So things like hope and the therapeutic relationship, those are things that are important to every theory, whether it's existentialism or cognitive behavioral or solution focused. So there's been a lot more focus on that. There's also been more focus on evidence-based practices and doing outcomes research to determine exactly what is it that makes counseling effective under what circumstances, and how can we replicate that with future people who have similar circumstances. So that is all in response to that there's an increased demand for accountability. And the accountability is being driven by lots of different agencies and governmental bodies saying, why should we fund your program or fund your organization or your agency? Why should we put you on our panel as a provider to be reimbursed? How do we know that what you're doing works? And so we have to do the research studies that will show why what we do is effective, because it is. There were some challenges during the 2000s that kind of shaped how counseling played out. And one of the biggest areas is that over the 2000s, the emergency departments listed here as the EDs were really overloaded with clinical cases, with clients coming in, patients coming in off the street that had mental health issues. And not every emergency department for every hospital has counseling or psychiatric services available. And so those patients who were coming in and having mental health issues were having to sit and wait for services, or getting transported to another hospital that might be hours away that did have those services. And you will know when you're working directly with those kinds of clients that that kind of situation only exacerbates the symptoms of a disorder. So definitely something needing to be addressed. And one of the ways that that is being addressed is to have a co-location of counseling services with medical services, so that patients receiving medical care can have easy access to behavioral health care, to mental health care at the same time. Another challenge that has come about to service delivery in the 2000s has been a focus on brief counseling. And brief counseling, when I started doing counseling, was something like 12 sessions, and now brief counseling is 6 sessions. It's very difficult to produce change. It's not impossible, but it is different it's a different way of being with someone when you know that you only have 6 sessions to be with them, and how you're going to concentrate your work and proceed, and what you'll expect to be a successful outcome when you only have 6 sessions. Next, the second bullet point here is all about the integration of technology into counseling. I mean, technology has just exploded during the 2000s, and it affects every aspect of our lives. In counseling, it affects the way that we keep records. So electronic record keeping is something that's really important. The way we communicate with clients. Now, is it okay to have a client on your Facebook or is it not? Should you text message with a client about their concerns or only about canceling appointments? What about if a client finds your email or tries to connect with you on LinkedIn? What about if you want to do distance counseling, and how do you set that up? And supervision, can you do supervision over Skype, and will that still be as effective as face-to-face counseling? Telepsychiatry is a response in part to what I mentioned in the previous bullet about the emergency departments being overloaded and not necessarily having mental health or psychiatrist services available in that hospital. So another way, especially in rural locations, and there have been some programs in North Carolina specifically that have been very successful with telepsychiatry, is to actually have the psychiatrist available via something like Skype, um, from a remote location, probably in a more urban environment, getting broadcast into the rural hospital setting that maybe doesn't have a full-time psychiatrist on staff or a psychiatrist on staff overnight. And then they are able to prescribe medication from the expertise of being a psychiatrist for a client in need. And then finally, here we also want to recognize the role that technology has on our clients' lives, their work-life balance, if they're getting cyberbullied, their online dating, all kinds of things. So we have to be familiar with those kinds of technologies and understand that they come with some benefits to social situations and relationships, and to workload, but they also create some stressors too. And we want to really be in touch with that. And on top of it, stress is important. It's a really big deal. It's a trigger to more serious mental illness issues. So we really want to understand how technology can pass on stress. In clinical mental health counseling today, many of you are likely to graduate and go on to work excuse me, in community agencies for the first couple of years while you have your provisional license. And then once you have your free, full, and clear license for independent practice, you might go on to work in a private practice. College counseling centers and public or governmental organizations are other areas where clinical mental health counselors are employed. The primary role of your job will be the prevention and promotion of mental health and the treatment of disorders and dysfunctions. And if you'll note, your primary role has not really changed much since President Kennedy in the 1960s enacted the Community Mental Health Care Act. And at that time, the primary focus was prevention and education and promoting mental health, but it ended up being more on treatment because that was the need. And so it's still today, in 2015, that's going to be the primary focus of your work. I thought you might enjoy seeing a little bit about what a typical day in the life of a clinical mental health counselor might be. I'll pause here for a minute as you read through. Okay, so if you haven't had a chance to read through the full day, then you can hit pause and read on your own. The last appointment of the day, 5 to 5:30, looks like it's been cut off a little bit, and that's complete case notes, renew ACA membership dues, print activity sheet for tomorrow's group counseling session, and prepare for outreach session at the hospital open house was the last thing on there. It's a busy day. There's a lot going on, and every hour provides something new, a different type of interaction, a different type of disorder that you might be working with. So it's definitely an exciting day. Scope of practice is something that continues to be very critical, very important for you to understand. Your book describes scope of practice. Scope of practice is what your licensure law in your state says that you are allowed to do or not allowed to do. I'm not going to read through all of the things here. Again, you can hit pause and you can read through this slide to understand what in the profession, the general scope of practice is presumed to be for clinical mental health counselors, but each state will have its own legislation that regulates the scope of practice of every trade, and counseling's no different. In North Carolina, for example, we have a really great scope of practice in our law, and so we're very fortunate. We can provide addictions counseling, individual counseling, couples counseling, assessments. But in other states, there are limitations on the general counseling licensure, the LPC licensure. So other states, if you were to move, you might find that you might not be able to do all of these things. And this is where it's real important that we advocate for our profession, and we advocate to make sure that our scope of practice is aligned with what your education and training has prepared you to do. We also, when we have an established scope of practice, we have a responsibility to not practice outside of that. So this last bullet point here, the limitations, means that you use your clinical judgment to do the best that you can in your counseling work, but you don't do work outside of that. And so that might mean you're not trained to write prescriptions, so you should not be giving prescription medication advice. That would be outside of your scope of practice, because while you're trained to know about psychopharmacology, you're not trained to provide prescriptions for it. So that's one area that is very important for counselors to realize that they have a limitation of. Another area that differs from state to state is with regard to assessment and testing. In some states, psychologists are allowed to do testing and counselors aren't, and that's been a bone of contention between those two groups for many years. Clinical mental health counseling today favors an integrative approach that is developmental and educative. So we believe that we need to conceptualize our clients' concerns from a developmental framework, understanding where that person should be in their life and where they actually are, and also developmentally thinking that the person is constantly developing. And so through the growth that comes from a counseling relationship, that person, even though they're having problems and difficulties right now, they can, with your support, work through them and continue to evolve and grow and develop. And we also always provide education, psychoeducation to clients about different issues. Next, we take a biopsychosocial approach to assessment and diagnosis. We look at the whole person. It's very holistic. We emphasize prevention, early intervention, and recovery. So we need to not just be dealing with things after the problem occurs, but also trying to catch problems early and provide people with information far enough in advance that maybe a problem doesn't fully come to fruition. We always look at the context of our clients' issues, including culture, socioeconomic status, and how that plays into their diagnosis and their access to care. And finally, we seek to empower our clients and families through advocacy. Sometimes I like to joke that we try to put ourselves out of business because we hope to give our clients the skills and the tools that will enable them to not need us and to go out into the world and to be able to do things for ourselves. Of course, the door is always open and they can always come back, and many clients do find that they need to tune up and come back in a year or 6 months after a successful bout of counseling and benefit from that tune-up session. So some leaders of the field were asked in a Delphi study, which is focused on building consensus among experts, to identify what were some trends in the future of counseling. And I have listed the results of that Delphi study here. One of the things that I want you to focus on is creating licensure portability. Throughout these instructor videos, part 1 and part 2, I've talked a little bit about how there's some differences from state to state, and with today's society being so mobile, it's really important that you're able to have a clear pathway to take your license from North Carolina with you when you move to Virginia or Alaska or Texas, wherever you may end up finding yourself. And this is a more detailed description of the 10 future trends in counseling. So please take a moment and read through these here. The trends that are happening, changes in the population, such as that there are more children and more aging populations, that directly informs some places where you might want to grow your private practice or target your specialty development in an area of expertise. Non-English speaking populations will continue to grow, so if you speak another language or are willing to learn another language, that will only make your employability go up even higher. Some of these other issues like diagnosis and treatment and licensure portability, we will talk more about those as the class continues. Thank you very much for your time, and I look forward to meeting you in person next week.